welcome to this morning's discussion of Psyfeld, the episode The Heart Attack. So, observations, where would the group like to start? No wrong answer.
George, after watching, I think it was called Coronary Companions or something like that, started complaining of having a heart attack during lunch.
Mm-hmm. All right, so George presents with the chief complaint of chest pain. And upon full cardiac workup, the cardiologists, the internists, tell him that there does not appear to be any organic pathology that would explain his pain, right? So generally speaking, what presents is usually referred to as medically unexplained physical symptoms, or MUPS. So you'll hear the term MUPS sometimes. Medically unexplained physical symptoms, right? Now, first and foremost, as a clinical pearl, and this, not that I'm talking to any third years right now, but if this were to appear on a shelf exam, you would continue to observe. That is, you have to have some level of humility that pathology and different clinical presentations sometimes do not make themselves apparent day one of the investigation. So this may be a progression, and that these symptoms may actually evolve over time. So it is always a best practice to have close follow-up, right? That's the general idea. For teaching purposes, we're going to accelerate this and just say that George's presentation remains within the realm of medically unexplained physical symptoms. Okay? And what we should discuss then is how we would like to approach George's presentation, how we would address George's concern that he's having a heart attack. In terms of some basic algorithm, because as probably, hopefully everybody recognizes on the outset, these can be very, very challenging cases. Especially, you put a physician in the situation in which they don't know what's going on. It just makes things very, very tenuous. So it's a really good idea to have a game plan and to have a very structured algorithm and approach as to what to do next. For that algorithm, what is one thing that we should consider here?
Effects of substances, maybe?
Always, right? If it's not a general medical condition, maybe it's due to the direct and physiologic effect of a substance, A and B, or number 1 and 1B, always, right? And that, by the way, could even extend and will extend to psychopathology as well. So if we think somebody's presenting with a depressive disorder, we're not going to call it major depression until we rule out the potential role of a substance and/or an underlying medical condition. Anxiety, same thing. Psychosis, again. So that you could go through every single chapter of the DSM and you're going to apply that. What else? So let's say we've investigated that, and similar to our investigation of an underlying medical condition, we're left thinking that there does not appear to be a role of a substance or substances in this case. By the way, again, shelf exam minded, if it were a substance, what substance would be at the very top of our list with regard to George's presentation? What substance intoxication notoriously shows up on certifying examinations with a heart attack? Yeah, cocaine, right? So any involvement of the nasal septum is cocaine until proven otherwise. On the psych shelf, chest pain is due to cocaine intoxication until proven otherwise. Right? All right. What's the next idea that comes to mind in terms of working through an algorithm and how to approach this very complex case of a medically unexplained physical symptom? First thing to consider, is there any evidence that my patient, George, is making a conscious effort to deceive me or provide misinformation in any way? Because in the absence of any such information that should raise your red flag, you're going to consider this to be a real and genuine presentation, right? On the other hand, let's go to that part of the algorithm in which there is evidence that presents itself to suggest that George is providing misinformation, our differential now becomes twofold. What's our two-part differential diagnosis in this case?
Malingering is one.
Factitious disorder.
Perfect. Right? There's two conditions in the DSM, malingering DSM-4, but nonetheless, both conditions can still appear on certifying examinations. Again, George Costanza is presenting with the chief complaint of chest pain. Upon presentation, we're going to now kind of edit the script where there is observable evidence that he is intending to misinform his doctors or TOR or everyone. In such cases, there are two things to consider, and one is called factitious disorder. Factitious disorder is the misrepresentation of symptoms for reasons that the patient is unaware of. So it is an unconscious motivation to misrepresent themselves. On the other hand, the other condition, formerly known as malingering, has the same exact presentation, but for reasons for which the patient is conscious and consciously aware. And certainly on a certifying exam, but even in real life medical practice, the question to the clinician is whether or not there is any observable external motivation as to why the patient is misinforming us. Because in the absence of anything that's external and externally motivating, we have to always default to the idea that there isn't any. Therefore, in this differential, it's always factitious until proven otherwise. And upon the reveal that there is some external motivating factors, workman's compensation, only then should we consider it to be malingering. Any questions about factitious or malingering? In the absence of any information that would support George Costanza is making a conscious effort to deceive us, therefore, in the absence of us having to consider, or information that would allow us to consider either factitious disorder or malingering, we go down the other way of the algorithm. And their differential diagnosis is also twofold. What is that?
Conversion disorder and somatic symptom disorder.
Right? Conversion disorder and somatic symptom disorder. Somatic symptom disorder is the larger, more overriding illness in which a person presents with a somatic symptom for which no underlying physical cause can be found. If that physical symptom happens to be voluntary motor and or sensory deficit, we call that variant of somatic symptom disorder conversion disorder. So even though conversion is really a subset and an example of somatic symptom disorder, it's common enough where the American Psychiatric Association pulled it out from under somatic symptom disorder and created its own diagnostic entity. In the case of George Costanza, there are your A, B, C, D certifying examination. A, factitious, B, malingering. C, somatic symptom disorder. D, conversion disorder. What is the single best answer? His troponins have come back negative. His EKG may show sinus tachycardia. Otherwise, there are no EKG changes that would suggest myocardial ischemia. There is no physical reason that would explain George Costanza's symptoms. What is the single best answer?
Somatic symptoms.
Yeah. Right? Everybody see how we got there? Any questions?
Wait, can you repeat again what that is?
Somatic symptom disorder is when a person presents with a somatic symptom or somatic complaint, such as chest pain, for which no underlying physical cause can be found to explain the pain. It's
It's like exactly what you're.
yeah,
So like when his arm goes like that?
yes. Yeah, that probably is more conversion. If we're looking at that as a motor function, right?
Sorry, motor. So
Yeah. Different episode, but we have the same algorithm. Now, there is another condition I have to consider here as well, and I don't necessarily think we would differentiate this because it could be a co-occurring condition. And that is when a person has significant anxiety about any of the above. In this case, the individual's anxiety is the result of a preoccupation. That is, they become preoccupied with having a serious illness. What condition am I explaining or describing here? Yeah. Being a hypochondriac, the former name hypochondriasis, the new name DSM-5, illness anxiety disorder, which is really in the continuum of an obsessive compulsive disorder. Illness anxiety disorder. Now, the DSM-5 did not republish illness anxiety in the OCD chapter, but it will. Right, so it still remains in the somatic symptom disorder chapter, but it's confusing that it is. So I think, especially for studying purposes, remove it, put it in its rightful place. It's really an obsessive compulsive and related disorder. Specifically, it's a disorder related to OCD. It's a preoccupation syndrome. The individual has a preoccupation with having or acquiring a serious illness, and George certainly manifests that as well. What if the preoccupation, again, Larry David came to us and wanted us to rewrite the script for educational purposes. What if we decided to edit the script so that we shifted George's preoccupation away from having a serious illness to having an imagined defect in appearance? What's the title or what's the label of that preoccupation syndrome?
Body dysmorphic disorder.
Right? Body dysmorphic disorder. And interestingly, in 2013, with the publication of the DSM-5, the APA did move body dysmorphic disorder out of the chapter of somatic symptom disorder and into the OCD-related disorder chapter, but left illness anxiety disorder where it is. So it's only a matter of time until that condition, illness anxiety disorder, formerly known as hypochondriasis, moves to the obsessive compulsive and related disorder chapter of the DSM as well. Any other observations with regard to George Costanza and the heart attack, his heart attack?
Would you want to think about panic disorder as well? Because that can often present with feelings of having a heart attack.
Yeah, and I think it's perfect timing for this too, because I think that enters into the conversation, the case formulation, along with hypochondriasis in terms of comorbidity. Right? We never want to miss co-occurring illness, because whatever illness we have diagnosed and B, treatment plan for, it's not going to get better. It's not going to improve to the extent that it would upon screening for identifying and then treating co-occurring conditions. So yes. That would include depression. That basically would include everything that you'd want to cover in a comprehensive psychiatric assessment. Yes. Other observations about George Costanza? Other characters, the heart attack. You guys didn't leave Tor alone, huh? He didn't strike you as somebody that was interesting?
I'm terrible with names, so I'm trying to think of
The healer.
the two relationships that we had, and then the anti-medical healer person.
Mm-hmm.
Yeah, that was an interesting.
About Kramer.
He seems to believe in the healer, and I think at the end of the episode, after the accident in the ambulance, he went to the healer and allegedly felt fine after that interaction.
Mm-hmm. Yeah. Now, again, I think especially within this episode, there is a significant degree of quote-unquote normality when it comes to Kramer. I think this is, again, I can't speak for Larry David, but this appears to be Larry David's subversive commentary on the medical field, which is justified, right? So we could start there, and this is, again, a clinical pearl. Anytime anyone presents to any doctor in behavioral health with a chief complaint, always consider that what you're seeing in front of you, what is being reported to you, is completely normal until it's not, right? So again, it's a way to train your brain. It's a way to really get into the position of having unconditional and positive regard for your patients. And that includes Tor. right? This is completely normal. It's culturally sanctioned. And that includes Kramer too. Now, when we move off of that initial starting point, we begin to look at what might be some abnormal behavior, and here abnormality is really a mathematical term, right? It's behavior that is not culturally sanctioned. For Kramer, and we'll cheat, we know that his eccentricities have resulted in clinical impairment. So not only does it appear to be abnormal, right, probability, outside the realm of normality, but it also, on some occasion, has resulted in clinically significant distress and impairment in Kramer's functioning. So not only is it abnormal, it looks to be disordered. So when somebody comes in, and maybe our patient's name is Kramer, and has these eccentricities of behavior that appear to be pathological, what is our differential diagnosis here?
If I might ask, when you refer to a behavior as mathematical, what exactly do you mean by that?
So when a behavior is outside of the culture's normative acceptance, we're considering it to be abnormal.
That's not okay. Oh,
Right.
so
Again,
it's
it really does kind of bear it down to statistics. Right. And abnormal behaviors that are clinically significant then are disordered behaviors. So just think along those terms. Right. Outside of a culturally sanctioned norm, right? It's all probabilities.
Right.
For Kramer, the words odd and eccentric appear in the DSM under the heading of schizotypal personality disorder. So again, if you've been called odd, if you've been called eccentric, if you believe you are odd and/or eccentric, completely normal. Until it becomes pervasive, and until that pervasiveness becomes disordered, right? Clinically significant distress or demonstration of impaired functioning, and that happens with Kramer. One of the things that we see in both of the cluster A personalities titled schizotypal and schizoid personality is that individuals with these conditions are usually physically, but certainly emotionally distant from others. And they really only forge relationships when they feel very, very comfortable with the person that they're interacting with. So it is really interesting that Kramer knows Tor, because Tor is also very eccentric. And here Larry David gets it right. These two know each other largely because, by definition, they are emotionally distant from people unless they are very, very certain that interaction is not going to result in some type of distress. So the fact that these two have a history is medically accurate and probably consistent with the schizotypal personality. The individual who is emotionally distant and therefore by choice lives the life of a hermit without the odd and or eccentric behaviors like the schizoid personality. And just to make sure we complete the uber brief primer on the cluster A personalities, what is the third personality disorder published in the DSM that is also cluster A?
Paranoid?
Yeah, paranoid personality is the final one. Right. The individual has a pervasive distrust and suspiciousness of others that is evident in multiple domains, is paranoid personality disorder. And Kramer certainly, in other episodes, has a degree of paranoia that's pervasive. And again, that is not necessarily a prompt to render multiple diagnoses, but instead to respect and appreciate that these conditions do tend to cluster traits. So by definition, people who have schizoid personality disorder tend to cluster, that is, incorporate both schizotypal and paranoid traits. Hence the name cluster. Final thoughts, any other character? Yeah, we're good. All right, we're going to end it here, and we'll check back at around noon for our film analysis on Groundhog Day. All right, catch you then.